thank you for that. I'm very glad that Rebecca went first. She's explained type 1 and type 2 diabetes, so we can move on. So I wanted to talk about diabetes in pregnancy and how we can improve outcomes, because there's a challenge at the moment in doing that, because and I'll show you why through my talk. So, gone the wrong way. So quite a long time ago, in 1989, a group of people came together, experts, public health experts, diabetic experts and health ministers from around Europe, to look at how we could make diabetes better. And for pregnancy, their declaration was that they wanted people who were pregnant with diabetes to have similar outcomes to the general population. That was 1989. So where are we? Well, no change in the past 10 years in the perinatal mortality rate in women who have diabetes before pregnancy. So you've still got a high rate of losses in women with type 1 diabetes. We've got more women with type 2 diabetes, and they've still got high loss rates. I haven't shown you the figures after 2019 because we had a high loss from, certainly in 2021, from COVID in the general population, with 12% of stillbirths in COVID being to women who tested, 12% of stillbirths being to women who tested positive for COVID. So what are the risks of pregnancy? Why is it so important? Well, if you've already got diabetic complications such as eye and kidney disease, getting pregnant can accelerate those diseases. You're more likely to have vomiting, and if if the diabetes has affected your gastric emptying, that could be quite persistent. But also the normal vomiting of pregnancy can make it difficult to control your blood sugars, and you can have low blood sugars, you can have high blood sugars. And throughout pregnancy, you're more at risk of getting diabetic ketoacidosis, which is an emergency, and we can talk about that later. So high blood pressure in pregnancy, preeclampsia, is a disease in pregnancy that gets better when you're not pregnant. We can reduce your risk of getting that by giving you aspirin, but also through monitoring. But if we can't control it, then your baby would have to be delivered early, and then it's at risk for the complications of being delivered preterm. As I've said, stillbirth has increased. You have an increased risk of that. And if you don't start off pregnancy with your blood sugars controlled, with a normal control of it over the couple of months before you get pregnant, you're more likely to have a baby with structural congenital abnormalities. So not a chromosomal abnormality like Down syndrome, but heart abnormalities or spina bifida. That's what I mean by structural abnormalities. Your baby might be too big or it might be too small, and we know the risk of stillbirth is increased in those babies. And also women are more likely to suffer a traumatic delivery with an increased risk of caesarean section, which is desirable to avoid if we can. So in the UK, we have a national diabetes and pregnancy audit that we're all supposed to put our figures into, and the last report came out in October of last year. And the key messages from that were that women with type 2 diabetes are more likely to come from ethnic minorities, and they're more likely to come from the most deprived backgrounds, so people that often have a difficulty accessing healthcare or don't get good healthcare. They also often have complex social and other comorbidities, social needs. Stillbirth I've mentioned, but the most modifiable risk factor is their blood glucose. So how can we get that to be better? So just to show you over the past few years, the changes, well, there aren't any really, and there are significant numbers of women who are pregnant with diabetes, both type 1 and type 2, and everybody thinks type 1 is more dangerous when you're pregnant. I think it's probably not. A lot more of those women are probably better prepared for pregnancy. But you've got a significant risk of having a baby with congenital abnormality. It's up to 4% if you've got type 2 diabetes. And you've got a significant risk of 2% of having a serious adverse outcome. Your hemoglobin A1C is a blood test that we can use to see what your diabetic control has been over the past 2 to 3 months. We don't just have to look at your blood sugars. And we know, if you can see this chart, the higher your hemoglobin A1C is in the last third of pregnancy, the increase the risk is of you having a stillbirth. So it really goes up quite a lot. Being deprived increases your risk of stillbirth, and having type 2 diabetes as well. The modifiable risk factor, and I keep saying it, is your blood glucose. So how can we help women get their blood glucose better? Well, we can help them improve their control before they're pregnant. They need to plan pregnancy with support. We can make sure they do all the normal things that we should be telling women to do before they get pregnant, stopping smoking, making sure you have vaccinations. MMR is something that we should be checking women's history of at the moment, certainly, which a lot of us forget to do because we've forgotten that women are immune to measles. But we can also modify the medications that they're on or give them a plan to modify it when they get pregnant. It's not always the best idea to stop medications that are controlling your kidney disease while you try to get pregnant, because it might take you a year to get pregnant, but we can give them a plan to stop it when they do get pregnant. The Saving Babies' Lives Care Package is something that NHS England introduced in 2016, and that package was initially designed to reduce stillbirths. It's in its third iteration. It came out last July, and it now has a chapter, an element on diabetes in pregnancy, and it's specifically diabetes that occurs before pregnancy, not gestational diabetes. So these are the key elements of it, and a big change for a lot of units will be that the recommendations are that if you start off pregnancy with diabetes, you are seen in a dedicated clinic. At the moment, these women tend to be seen in a lot of units in clinics that have women with gestational diabetes. They are big clinics, they tend to overrun, and it means you dilute the expertise amongst the healthcare professionals that are there, and you might not get to see the right person. If you start off pregnancy with pre-gestational diabetes, there's a lot more tech involved. You might have an insulin pump, which I can't adjust, and I can't tell you how to adjust. That's out with my area of expertise, so I'm not going to help you with that. You might have a glucose sensor. There's a whole lot of things. You need more time and you need continuity, and you can get that from a dedicated clinic, but that will take service redesign. Continuous glucose monitoring is extremely important, and I'll show you a study in a minute showing why it's important in pregnancy. But everybody who has type 1 diabetes, not everybody wants it, and we need to explore that with them, should have continuous glucose monitoring. For women we haven't got their control right, if we know at the start of the third trimester, about 28 weeks pregnant, that their hemoglobin A1C, so the sugar's not been right over the past 2 to 3 months, then we need to identify those women by doing the blood test for the first of all, using our multidisciplinary team to see what have we done, what else can we do, how can we engage it, and try and improve their control, improve their fetal monitoring, and maybe we need to deliver them earlier. Some units don't see very many women with pre-gestational diabetes. Some might see 30 in a year. Of those women, not very many of them will have eye disease or kidney disease, so they don't have a lot of expertise. But those women tend to stay in those district general hospital clinics without access to maternal medicine specialists, but with general people who are not bad in themselves, but they don't have the experience. So the recommendation is that those women come to a maternal medicine centre. They might have difficulty travelling, but we've got telemedicine options, so everyone doesn't have to come, but we think the outcomes will be better if they come in. Because we do see women who are not treated properly in the district general if you don't have a lot of expertise. And I'll tell you now, if you are an obstetrician and you have somebody who's got a complicated pregnancy, if you deliver them, it's somebody else's problem. But actually, delivering a baby prematurely is not in its best interest. It might not be in the mother's best interest. If you're with someone who week in and week out deals with complicated pregnancies, you're less likely to be delivered preterm and more likely to be delivered appropriately. So you can all go on and look at your local units and see what their outcomes are. I've got a link at the end. I'm showing you my unit because the outcomes are good, because one of my colleagues produced the Saving Babies' Lives Care Package, and so most of this is in place. Not all of it is in place. You might not think it is particularly good outcome, but it is when I'll show you in a minute. About a fifth of our babies are admitted to neonatal intensive care, and less than a third are, 28% are delivered preterm. And the fact that the number delivered preterm is higher than the number that delivered are admitted to neonatal intensive care unit tells you that they are late preterm delivery, so they're probably delivered after 35 weeks. And about a quarter of our babies are large for gestational age, which I said it was a risk factor. Now, not trying to be tribal, but I have picked Liverpool here because it's a similar size unit. It's not that we're in competition at all. Slightly different units, although we've got similar numbers of deliveries, there are more white women in Liverpool in their population. Differences here. You've got a high number of babies going to neonatal intensive care, 43%. with a lot of them delivered preterm and a higher number of large gestational age babies. So marked differences. Now, as I said, I worked for the CQC and I did an inspection late last year in a unit that had 2 different sites. It wasn't Liverpool, 2 different sites. They hadn't merged that long. One site delivered about 30 women with pregestational diabetes, the other one about 200. The chart was exactly like this when I put them on. So the unit that delivered the small number of people had the highest admissions to neonatal intensive care unit, the highest preterm delivery rate. And the kind of shocking thing for me was when I showed the clinical director in that unit, have you seen your NPID results? No idea. Thought they were doing everything okay. They had a unit that they're twin with, they're part of the same unit, that's got much better. It's just down the road, although I've driven it, it's not that close really. But they have got people in that trust that have got the expertise to improve their outcomes. And so we need to share learning. So how do we support people to optimise their glucose control? Well, I think you'll find if I asked you to talk to your neighbours about, who you're sitting beside today, when do you eat, when do you go up, when do you sleep? We have women who go to bed at 2 o'clock in the morning, even with young children, get up at 11 o'clock in the day. They eat differently. Everybody has different meal types. You cannot just be prescriptive about what people eat. If you remember, I remember the story about Steve Redgrave when he was diagnosed with diabetes. He was told, this is what you have to eat. You eat 2,500 calories a day. You do this. And he was collapsing. I think he collapsed at a petrol station because he was burning 6,000 calories a day, but he'd been told he was diabetic, therefore this is what you do. So you have to individualise the care. Continuity of care is going to work because you need to find out, what's going to work with that person. What can you do? What different strategies can you try? And women do need to know that there are risks in their pregnancy, but you have to give them solutions. Don't just beat them up with, this is going to happen, you're going to lose your baby. How are you going to make it better? How are you going to help them? Because they'll switch off if you don't engage with them better. So we think all that's going to be better in a dedicated clinic. The concept study was published in The Lancet in 2017, and this looked at women with continuous glucose monitoring. So that's one of those sensors that's monitoring your sugar all the time, and it comes out. And there was women in this study that had insulin pumps, but also were given what we call the basal bolus regime, where they're injecting insulin. And that showed that much better outcomes just by using continuous glucose monitoring. Your baby not being large for gestational age was reduced. They were less likely to have low blood sugars and less likely to be admitted to intensive care. And this is what you get. You get this kind of printout from here. It shows you where your blood sugars are, shows you where the highs are, and you can work out how often your sugars are in target. Now, I don't think anybody would get 100% in target, even Rebecca with her son. But we do know that if you increase your time in target by 5%, you increase your pregnancy outcome. So that's the important message. However, there's still some work to do, because we know that women from ethnic minorities and deprived backgrounds are not using continuous glucose monitoring as much as they should be, or as much as we want them to be. And that's partly because they're not being offered it, but partly because it's not been, they haven't bought into it, they don't understand. There's education probably on both sides, and we need to understand the barriers. Some people don't want to know what their blood glucose are all the time, but I think probably people cleverer than me can engage with them to help and help them understand why it's a benefit to them. We have a traffic light system that's advised by Saving Babies' Lives. If you check somebody's hemoglobin A1C, see what their sugars are like when they're 28 weeks pregnant, and then you can change their pathway of care. So, discussing them and changing them. We've never done that before, really, and I think it's a good way to go. So, there's some of the principles of diabetic care. Really, we want to keep people healthy during their pregnancy. If we keep the women healthy, we'll keep our baby healthy. We'll stop the women's complications progressing or developing, and actually you'll produce a baby that has been in a better metabolic environment, and its lifetime risks of diabetic complications are reduced as well. Preterm birth, as I've said, it's great to get a baby delivered, give it to the neonatologist, everything becomes somebody else's problem, but it's not the answer. And actually you can safely get women much further on in their pregnancy if you're looked after by people that are used to dealing with complicated pregnancies than if it's the one person you look after in a year. So I think in summary, it'll take investment to do this. People have to buy into it. There has to be some mental buy-in. People have to change the way they're working, but also, if you're going to set up a dedicated clinic, that takes, the department's going to have to invest in that, as well as not just changing mindsets. It is how I think we'll improve outcomes, and I hope I've shown you from our results that it does improve outcomes. And I hope you agree that women and babies deserve better. So if they've been better than the treatment they're getting just now, we can do better, I think, when we've got the tools. Okay, I'm going to leave you with a picture of one of my beautiful midwifery colleagues and her young baby. She lets me use it with permission. And I just acknowledge my colleague, Professor Jenny Myers, who was one of the authors of Saving Babies' Lives, who's given me some of the slides.